Welcome to Section 3 of Chapter 2, Value-Based and Shared Savings Overview.
We're now going to talk about shared savings or value-based contracting as a methodology. This is something that's relatively new. It's being sort of designed as we speak. It is about literally saving money to the health plans in a number of ways, and then sharing, the provider sharing in those savings. So health plans, commercial health insurance is all about risk. They're taking a risk on the patient population that they cover. They have a budget, and typically that budget is based on historical utilization. So they know that a certain population, they have lots of science that says a certain population, age, sex adjusted, all of those things, have a certain amount of cost based on the community that they live in. They have this budget. If you can beat that budget, then there's savings. In these kinds of programs, it's actually really kind of interesting where they're going to share with you some of that savings. It could be really exciting. It's really a great partnership with a health plan.
To participate in a shared savings model, the health plan will likely require that you track and report your quality measures. This is something that you are already doing as part of the SIM initiative. Keep in mind, you will want to understand what the measures are and how the health plan wants this information reported.
They're going to use these quality measures and reporting to then come up with how you're saving money. So when we talk about the relationship you have with a health plan, it's about this data transfer. They have a lot of information, you want it. You have a lot of information, they want it. You want to have a good relationship where you're going back and forth, supplying them with what they need, and then having them supply you with what you need so that you can maximize on your care, maximize on opportunities for care, and definitely maximize on lowering overall costs. A big way to lower overall costs is the relationship you have with other providers. So for example, if you have a patient that ends up in the emergency room of your local hospital, you want that hospital to be communicating to you as fast as possible that one of your patients, one of your attributed lives, is in their facility. Again, in a shared savings situation, you're trying to lower overall costs, and then you're going to get a piece of that. You're going to get paid for helping them lower overall costs. But you can't do that unless you know what's going on. Your referral network, for example, you want to work with people that understand that you're in a shared savings situation. So you don't want them doing more than they should. You want them to do exactly what's needed and exactly what you're referring the patient to have done. As you know a lot better than I do, chronic conditions have at their base oftentimes behavioral health or mental health issues. That's why this is so important, and that's why this makes so much sense, is getting on top of those core issues can save on those chronic conditions. You're saving the health plan, the payer, money because you're getting kind of on top of this. But the issue becomes, prove it to me. If I'm a health plan, I'm going to say, I get what you're saying, but you have to show me. So you want to work with the health plan with using their data and yours to show that perhaps, and this is just an example, that your ER utilization is lower than the market, that your inpatient days are lower than the market, that you're using generic medication as opposed to name brand medication, saving them money that you should get paid for. You should get a part of that as their partner in providing the best care to your patients every single time. One of the things you want to really watch out for in a value-based contract arrangement is what we call the race to the bottom. We always look for this when we review language in a contract where there's a value-based or shared savings arrangement. Each year has a budget. So you might have, a budget that says that if you beat the budget, we're going to share back to you, 50% of the savings, just as an example. You don't want that budget to be reset every year lower and lower, because you might find at the end you're doing all this great work, you're doing all the right things, but you've really pushed all the cost out of the system, and then therefore after doing all this great work, there's nothing left for you. So watch for race to the bottom contract language that year after year they're resetting that budget lower and lower. Again, it's about a partnership. You should have a transparent relationship with a health plan, and really insist upon it, that if you see that race to the bottom language, you want to point it out to them and say, how is it that I'm going to be doing all this really hard work, working with my referral network, working with the hospital, establishing all of that communication that's going to help you save money as a health plan, but as we wring all that savings out, you're really not paying me to do it. A good example of race to the bottom language is going to be, it'll be worded something like there's a year after year adjustment. So you might be signing, say, a 3-year contract, and the budget starts on year 1 as X, and in year 2 it's less than X, and in year 3 it's less than that. That's that race to the bottom where they're having you find ways to save the health plan money, but they're giving you less and less for it. You don't want to have that kind of relationship. And if you see it, point it out. Ask them. Have a conversation about it. Why is this language here? Why don't we work together to find savings, work together to then share in those savings?